Hello, my name is Dr. Brian Lippincott, and it's a pleasure to be with you on this channel. I'm going to give you a little lecture now about alexithymia and some of the measures like the TAS-20 and how to measure alexithymia with your clients. And this is to give you a general idea of alexithymia, which is the ability for a person to talk about their feelings. So you can see us psychologists and therapists are always talking about our feelings and requiring that from people. So especially when there's trauma or other issues that are deeply embedded in the person and somewhat secretive, it's hard to talk about things like trauma for all of us. But for people with alexithymia, they have lost in their ability to talk about trauma, and it requires sometimes for us as therapists to use a variety of different ways to contact them. And this can also be true of sometimes of people on the spectrum or some other issues that children and adolescents and others might have that can be helpful for you to know about. So I'm going to share my screen now and start the lecture.
Okay. Okay, thank you, computer. Okay. So again, this is the alexithymia test, the Toronto TAS 20. It has 20 questions, and you can see some of them here. I prefer to watch light entertainment shows rather than psychological dramas. It is difficult for me to reveal my innermost feelings, even to close friends. Okay, so let's see here if I can know how to do this without stopping sharing. Okay, and now again, share screen. Okay, and I will email these lecture notes here to you also. Okay.
Or I will leave it in
Okay.
the show notes. So
Lecture on the Toronto alexithymia scale. Okay. What alexithymia feels like. And it shows when trying to think of emotions, all I can picture in my head is static. I often feel neutral. I don't know. I feel, but I can't remember it. This is just a little picture that shows what alexithymia is. The Toronto Alexithymia Scale is the most widely used self-report tool for alexithymia, which alexithymia is a personality trait characterized by difficulties identifying and describing one's own emotions. And I first experienced this way back in the day. When I first started my practicum, I got a lot of Vietnam vets, and they would come in with their partners in couples therapy, and it's like he can't talk about his feelings. He won't talk about his feelings. And I thought, okay, he's just resistant, or it's. But the person really can have alexithymia, which means that they don't know what they feel. They're not lying. They really don't know what they feel, and they have a really hard time talking about it. And we can talk about this. I'm going to give you some case studies here, and we're going to talk about that. The structure and the factors. 20 items, as you saw. It's a 5-point scale from strongly agree to strongly disagree. And there's 3 subscales. Number 1 is difficulty identifying feelings, the diff, assessing the ability to distinguish between feelings and bodily sensations of emotional arousal. I am often accused about what emotion I'm feeling. So I have a little side. My son was a running back with Colin Kaepernick at University of Nevada, and that was the only team ever in college football that had three backs that had 1,000 yards rushing in a season, and because of that, I had a lot of experience in sports psychology of people not knowing what they're feeling. Okay, because you have to repress a lot of that, and so they weren't able to identify their emotional feelings because they learned to suppress that. So there are repressive coping, which is what this is about. When you have a trauma, you repress a lot of things in order to cope. But that only works in two areas. People that get a diagnosis of cancer that use repressive coping and say, I don't care if 95% of the people die, I'm going to live. Those people significantly live more. And the other people that are use repressive coping and it works are athletes. If you strike out in a baseball game, you can't go out in the field and be thinking about striking out. You got to have really a short memory and repress all that. But in real life, that does not help at all. So difficulty describing feelings. So they can identify a feeling, but if you think about, let's go back to number one, identifying feeling. The same when somebody is like when you're going to play in the Super Bowl. There's a lot of emotional arousal that happens. Now you can think about that and label that as I'm excited or I'm ready for the game, I'm pumped up, or you could look at it as I'm having butterflies and I'm having an anxiety attack. So with athletes, we really have to help them identify their feelings and many times reframe the same thing with trauma. In fact, the same physiological, when somebody is sexually aroused and somebody is in a fear state, the same chemicals are turned on in the body in both those states. So we want to use the term arousal, or we want to use the term excited, and not in order to help them identify that. But these people have difficulty really even identifying any feeling or describing their feelings, like putting emotions into words. It's difficult for me to find the right words, and there's a lot of brain things that are going on there because they're. If you remember what Bruce Perry said. If you're locked in, if you've had early trauma in the early parts of the brain, and you probably can't see me, but I'm sticking up my hand with my thumb down. In that early part of the brain, those kind of things that are stimulated, if you can never get up to the part of describing what the feeling is because you're stuck down here and you're experiencing this hotness because you were traumatized right when your temperature regulation, like Bruce Perry was able to go to the Branch Davidian kids when there was a big bunch of traumatized kids, because the FBI broke in and all that. You might not know the story. It happened about 20, 30 years ago. But he was able to tell which kids had PTSD by taking their temperature. Because temperature is dysregulated when that trauma, but you can't label it. Now, the third area is externally oriented thinking, like severe extroversion, focusing on external details of events rather than internal experiences. So why would a traumatized person do that? Is they're repressing. They have to hold that. If I really think, oh, there's $1 million on this game, I'm playing in the Super Bowl or whatever, you're gonna fumble the ball. You got to think at that particular time. What you want the athlete to think is, I'm in the third grade. I'm gonna just pretend. I'm gonna let it loose. I'm gonna just fling the ball around. But these people are so externally oriented that they can't look at their own. I prefer to analyze problems rather than describe them. Okay. Scoring. So on that scale, if you have 20 questions, you're going to get a score from 20 to 51. And I have two cases, Tom and Sam. Tom he has to see, and they have the same trauma when we get to that. They have the same exact traumas, but they have different scores on this test. So how are they different? That's what's going to help you kind of understand the clinical significance of this. While not a diagnosis in itself, alexithymia is strongly associated with several mental health and medical conditions, often influencing how individuals respond to therapy. Like, it's highly prevalent to have alexithymia in autism spectrum disorder. Psychosomatic things like chronic pain, asthma, therapy outcome. Higher scores can predict difficulty and establish a therapeutic alliance or a higher risk of premature termination. So having alexithymia can, if you don't address it and know that it's there, it can make. Imagine if you couldn't talk about your feeling, but your therapist was asking you, how do you feel? How do you feel? How do you feel? You're not going to want to go back, right? You have to learn other ways, which we'll talk about, of connecting with people if they get a high. And this goes to the reliability and the criticism of it. Many researchers suggest the DIF and the DDF scales may overlap. Yeah, okay. So like a lot of things, I want you to know that. I will email this to you, but I'm not going to spend too much more time on that. So clinical formulation and strategy, which you're going to be doing in weeks, you're going to formulate it and come up with a strategy. So it helps therapists identify roadblocks, like high scores on difficulty identifying feelings warn therapists that the patient might struggle with goal setting or articulating their core issues. Okay, bridging communication, high difficulty describing feelings scores alert the clinician that mutual understanding may be difficult, potentially hindering the therapeutic alliance, hard for them to bond. Addressing the external orientation. Patients with highly external oriented thinking scores often focus on situational details rather than internal emotional states. So they don't know what they're emotional. They're looking at the detail. The guy was showing his teeth to me or whatever. That's an external thing where they might be focused on some detail, not on their internal feelings of what they feel. Like they might not even be able to say, I was scared. Okay. Predicting, and some of you that work in law enforcement, you might understand that because people can't. That would be like, for instance, if I was really fearful of somebody and I injured them or killed them or whatever, a good defense was I was really scared. They were assaulting me, and I saw they had a knife or whatever, but. They don't have. Sometimes people with alexithymia don't have the ability to say I was scared. I felt threatened. All those things that in a legal thing could be really important. So predicting therapy outcomes like treatment preference. Research indicates that individuals with high TAS-20 scores may sometimes prefer group therapy over individual sessions, though they may experience poor outcomes in both if the therapist does not adjust for their lack of emotional expression. Substance use recovery. In addiction treatment, higher scores are associated with lower rates of maintaining abstinence and poor overall engagement in the recovery process. And that's because it's all about repression. And what do substances do? They help you forget your problems, or at least the ones that people have trauma. People that have trauma aren't really taking a lot of psilocybin, different LSD, hallucinogens. They're taking things that like opioids or things that kill the pain, right? Because they're in emotional pain from having trauma. So alcohol is a really biggie with them. Okay. And I have noticed with clients that I've had, that people that have low scores on this prefer indica cannabis to sativa cannabis. And I don't know exactly what the differences are, but I know they prefer and I've heard from them that it has more of a body high. And that's what they're trying to do is they don't want to feel things. So interventions. How do you tailor your interventions? Remember in week 3, mindfulness-based body therapy. And I'm going to give you a lecture, not today, but some other time, about mindfulness-based therapy with trauma. Cognitive behavioral therapy, modified by lowering T20 scores by focusing on emotional lability and literacy. So being like, you might even with an adult, bring out the list, like in Marshall Hanahan's DBT, they'll have a list of all these feelings. So it's not just angry or sad. It's all these, I'm frustrated. I'm I'm out of sorts with this, but they have a lot of different words that you can pick for the same thing to teach, because people have to learn words. And those of you that are working in the school, the single greatest positive effect of having therapy for children is that children that attend psychotherapy are more able to talk about their feelings, which makes sense that they develop by having this safe place. Nonverbal therapies, for those who cannot find words for their feelings, music or art therapy. I'm really big on poetry therapy, or even things like saying, okay, you can't describe how you feel. Over the next week, listen to all the music you listen to and pick the one song that might represent how you feel, and then and the song will give you the emotions. But music therapy, drumming, being in nature, these are all things that people that are high on this can really relate to. Okay. And I have found psychosis really relates to being in nature. The youth would tell me all the time, like, it doesn't get rid of the voices, Brian, but when I'm out here in the woods, because in Monterey County, we have Big Sur, we have all these wonderful beaches, all this, and they would really do better when we would take them out in the woods. Okay. Authentic movement. One example created by Marion Woodman, a Jungian analyst in Toronto, invented a treatment called authentic movement, which really helps with trauma. Authentic movement, you can all look it up. You all got computers. And trauma treatment involves movers exploring internal impulses with eyes closed. That's the interoceptive. Like, can you try to feel your heartbeat right now? A lot of people that have alexithymia can't, they have trouble with somatic experiencing that. Authentic movement in trauma treatment involves movers exploring the people moving, internal impulses with eyes closed, guided by a witness to release frozen states and reclaim their bodies through spontaneous movement, often followed by drawing or writing to integrate the experience, including breath-centered movement. And I have found when we talk about mindfulness, I will say, you don't want to start with mindfulness, because sometimes people that have trauma, they can't even close their eyes, or they can't even, being mindfulness is like hell to them. What you want to start off with is breath work, because they've learned how to emotionally regulate themselves with the breathing exercise, like box breathing. Breathe in for 5, hold it for 5, breathe out for 5, hold it out for 5. And you do that like 4 or 5 times, it will regulate your polyvagal system and will help you deal with these experiences. And so you want to start with breathing. You don't want to start with mindfulness. Mindfulness can be threatening for people that have trauma. Okay, grounding exercises like stomping, flowing waves, expressing past traumatic moments somatically, fostering nervous system regulation. Like, one of the things that really helped a lot with the teenagers was those little round trampolines, just jumping on that and getting into a rhythm. Because if you were traumatized, really, the rhythm you didn't get that. And some people are, I really believe, some people are traumatized in vivo, where that child, when they're inside of the mom, hears the parents arguing, and if that child hears that yelling and that different type of voices, they're going to respond to that, and the child comes out. I've seen it working with people. I don't know why they picked me, but I worked in a center when I first started out for young women who had gotten pregnant and needed a place to stay. And several of them asked me to be a birthing coach. And they would, for instance, one woman was severely abused growing up. And she said, can you be my birthing coach? And it was a really interesting experience for me. What happened was, when the baby came out, and you know how the doctor grabs the baby and is going to put it on the mom's chest to get skin to skin. Those of you that have babies know about this. And put it on the chest is what the doctor wants to do. And the baby was reaching out to the mom. And the mom says, look, Brian, it was a boy baby, he's already trying to scratch my eyes out. So the mother interpreted this reaching out of the little baby as being threatening to her because of her past experiences. And it turned out that she wasn't able to keep the baby. It was a whole, again, things getting passed down. But okay, the mover, closing eyes and waiting, spontaneous expression, making sounds, whatever that you just get them to enact anything. Somatic revelation, movements can be physically manifest trauma, such as feeling frozen or heavy or replaying past events. When the people start doing authentic movement, it can trigger emotions and losses. The witness, non-judgmental presence, providing feedback. Like I noticed a heaviness when you moved in this particular movement that you were making. Okay. And then you have post-movement integration. Okay. Just like in psychedelic therapy, the most important things are the integration sessions afterwards, which is becoming a new wave of thing that a lot of vets have. There's a lot of good research coming out of MAPS, which I can't remember what MAPS stands for now, but it's in Santa Cruz and it's for psychedelic therapy. It's becoming a much more well-known thing. Okay, so let's see, and then usually drawing and writing and describing the experience in the present tense. Grounding, stop, flowing waves. Again, we went over that. You can look at this if you have more time. Measuring progress. So this will help you in your signature assignment. Like, how are you going to know if the person gets better? It's used as a measure before and after treatment. Successful psychological interventions often lead to a notable drop in TAS scores, indicating better emotional awareness and regulation. Now, in my particular thing, I'm a Jungian. That was my first therapeutic language. In Jungian psychology, trauma is often viewed as a fragmentation of the soul, where painful experiences are walled off from the conscious ego. Okay, so we're going to get into an example. For Tom and Sam, their shared history of abuse has led to distinct psychological adaptations. As their therapist, the TAS-20 serves as a vital compass, guiding the direction of therapy. Is it working or not? So here you have, let's see, we have a picture of Tom, the silent reservoir. Okay, so you can look at that picture and see what how he might present in his body language. His profile, high TAS scores on DIF and DDF, okay, describing feelings and experiencing feelings. In Jungian typology, he's an introverted thinking type. So he's very introverted into his own head, but all having to do with sensing and details and very judgmental on himself. And they both have the same trauma. Tom is trapped in a loop of somatic trauma. His SI, which is somatic introverted sensing preference, leads him to score meticulously painful sensory data from the past, manifesting as vivid flashbacks and hyperarousal. Simultaneously, his high TAS scores indicates a profound emotional numbness, which is a key word that's part of one of the symptoms of PTSD and just general trauma. Is I feel not. That's why you get people cutting. Ask them why they're cutting. As I couldn't feel anything, but I cut. All of a sudden, I felt better. It's a way of shifting their emotion when the person is so numb. Yeah. And what you want to do when people cut is you want to really go, oh, let me look at your cut. Oh, let's put some medicine on it. Let's put a bandage. You want to really nurture them because usually it comes for people with trauma that weren't nurtured. So emotional numbness is a protective dissociation, which we'll talk a lot more about dissociation, where he cannot bridge the gap between his physical sensation and emotional levels. So imagine when you get down to your final thing, the final assignment is about somatic and emotions and how you're going to understand that. So this test would be one that and so what you would do is you just go over that test and pretend your case study, you just pretend you're answering it as the person in your case study. And you'll see you can try a couple different ways think of different people and answer the questions differently. It'll give you an idea of how to use this measure and all measures. In a second, when I'm done with this, I'll show you how to get a hold of some measures. Presentation. Tom is trapped in a loop of, okay, I talked about that. profound numbness, therapeutic process, music therapy was really helped with him. Because he lacks words for feelings, he's very high in the DDF. We begin with receptive music listening. We use resonant, wordless compositions to mirror his internal numbness. Gradually, we move to improvisational drumming, allowing him to externalize the rhythm of his anxiety or whatever feeling he has. The rhythm of it. Is it ba 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 ba? Is it ba ba? Whatever. Is it throbbing pain? Is it stinging pain? You know, you really want to get it more, help him describe it through the music. And it's going to start off with a rhythm or a beat. Authentic movement. His body is locked. In authentic movement, I serve as the witness while he moves with eyes closed, allowing his body to express the unthought known of his abuse that he can't think about, but he's experiencing that. And it might take a month to get him to be able to even close his eyes in this particular client. This bypass has difficulty in identifying feelings by letting the body speak first. So what does your body say? And you see his fist, all, you know, whatever it says. Oh, that might be anger. You don't tell him that, but you might discuss that. Dreams. Tom's dreams are likely literal and terrifying. We don't analyze them intellectually. Instead, we re-enter the dream, go back into it, and try to shift. Like, oh, these guys are chasing you, and they have big clubs and stuff. Let's turn and talk to them in therapy, and we re-enter the dream. That's dream re-entry. That's a famous dream technique. Okay, and there we have Sam. He's the detached observer. He has high EAT only. His TAS is relatively low, okay? But he has only high in EOT, the external oriented thinking. And he's an extroverted thinking type. So he's very extroverted. So presentations, Tom's low DIF and DDF suggest that he can label emotions intellectually, but his high externally oriented thinking means he avoids looking inward. Of what the meaning of that to him and how to really feel. He can remember the things and discuss it, but it's kind of like when somebody discusses something, but they're not really, they're not congruent. In other words, they're saying, oh, when my mom died, it was really hard. You know, I remember my dad hit it, but it's not, it's really hard for me to do it because I'm such a feeling type. I almost always have emotions in my things, but this person doesn't. He's highly distractible and depressed because he's constantly projecting his energy into external facts and logic in order to avoid the void of his internal grief. So he's avoiding these feelings, which is this all kind of is based on repression or dissociation, and we'll talk about the difference of those. In Jungian therapy, trauma is often viewed as, and so here we go with the treatment for this one. He's trapped in the loop of somatic trauma. His SI preference leads, this is Tom, where I want Sam. Must have skipped something. Sam, okay. Here we go. Music, we talked about that. Okay, authentic movement for Sam. Okay, music therapy. He enjoys structure, Sam does. We construct songs about his external world, slowly inserting feeling words into the lyrics. So it's like St. Augustine said, thank God we're not responsible for our dreams. I mean, everybody dreams of murdering people at some time or all kind of sexual things or whatever it is. So we're only making a song or we're only singing a song, okay, or a poem or whatever he's interested in. We could use drawing too. But he's learning the feeling words. In authentic movement, Sam may find this silly or illogical. It's childlike. Well, but he didn't really have a childhood growing up because of the trauma. He had to grow up. So many of these kids had to grow up too soon. So they developed a high externally oriented thinking in order to repress this. By focusing on the micro sensations of movement, what did you feel like when your feet were really stomping the ground? What is that? Like, what does that mean to you? How do you feel that in your body? Okay, we challenge his EOT bias and force a confrontation with the introverted feeling, his inferior function. So it's part of his individuation process to really feel these feelings, and it's part of his healing if you're going to work with him. Okay. He likely dreams about machines, logistics, or being lost in cities. We use these objective images to discuss his subjective state. So I'm lost in the city, but he's just describing it. How would somebody else feel if they were in, or how do they, what do you think is their bodies? What do they feel that in their body when their head is moving like this? And I don't know if you could see me, but he's moving his head and his eyes are darting. He's saying, he's showing you now, how would that feel? Oh, I feel like people are out to get me. Whatever. He was able to come up with the feelings by these movements and by his dreams. Helping him realize that the broken machine of his dream is a symbol of his own depressed vitality. He's inhibiting himself. Okay. Okay. Importance in measuring for progress for Tom. A decrease in the DIF and the DDF subscales marks success. It indicates that the music and movement are successfully thawing his numbness, allowing him to finally name the fear which previously only existed as a flashback. For Sam, project is measured by a decrease in the external orientation score. In retesting, every 3 months, the TAS provides objective proof that the individuation process of making the unconscious conscious. That's the goal, is you're making the unconscious things that he's repressed conscious again. And the fragmented soul, the fragmented being that he has, you're making it whole again.
Okay. Well, thank you very much. I hope you enjoyed that presentation on the alexithymia scale. And we're also going to go into some other subjects. Aphantasia will be one of our next lectures, which is about people that have trouble imagining, using their imagination. How would a Jungian-oriented psychologist, an analytical psychologist, or anybody that's working with people deal with them if they had trouble with visual imagery? Well, obviously, we have to try some other techniques. Okay. Thank you very much, and I'll see you on the channel later on, I hope. Bye-bye.